So today the topic of the video is management of pneumonia. That is the continuation of part one of our pneumonia topic. You have to know the management of pneumonia, and you have to learn the antibiotics for pneumonia very perfectly because AMC loves to test which antibiotic is for the pneumonia according to the severity, and if the patient has penicillin allergy, which antibiotics you are going to replace, what are the first line antibiotics, what are the second line antibiotics. You have to know all of that. So without further ado, we are going to start our video with the heading of low severity community acquired pneumonia. So in the previous video in the algorithm, I have already mentioned what is the low severity community acquired pneumonia, which do not require the hospital admission. So the first line treatment for the low severity community acquired pneumonia is the amoxicillin. Amoxicillin is the first line treatment for low severity community acquired pneumonia, and initially the patient has to be treated with monotherapy. Yeah, we are going to give the single drug, that is amoxicillin, to the patient of low severity community acquired pneumonia. But if you are suspecting the atypical pathogen, or you have the results of culture and the pathogen is atypical, that is Mycoplasma or chlamydia, we are going to give the patient the doxycycline and clarithromycin. Also, if the patient has hypersensitivity to penicillin, we cannot administer the amoxicillin. And in place of amoxicillin, if the patient is hypersensitive to penicillin, the first line treatment for low severity community acquired pneumonia would be doxycycline or clarithromycin. So if the patient is not improving on monotherapy, first of all, we are going to assess other differential diagnosis. If the patient has any other diagnosis, we are going to assess the patient first for that. Then we are going to be moving forward towards the combination therapy. And the combination therapy for low severity community acquired pneumonia can be amoxicillin plus doxy or clarithromycin. Doxy or clarithromycin plus amoxicillin. But if the patient is allergic to amoxicillin in the combination therapy, so in place of amoxicillin, if the patient has non-severe hypersensitivity reaction, immediate or delayed, we are going to administer the cefuroxime in the combination therapy. And if the patient has severe hypersensitivity reaction, that is immediate or delayed, we are going to seek the expert advice. So let me summarize the treatment for low severity community acquired pneumonia. First line is monotherapy, that is amoxicillin. But if the monotherapy is not working on the patient, or the patient has any comorbs or that are advanced heart disease, kidney disease, or liver disease, and you suspect that follow-up is not possible, hospital is far away, or the patient is traveling, or for any other reason, the follow-up is not possible, we are going to be giving the combination therapy, that is of amoxicillin and doxy and clarithromycin. In monotherapy, if the patient is allergic to penicillin, we are going to give the doxy or clarithromycin. But in the combination therapy, if the patient is allergic to amoxicillin, if the hypersensitivity reaction is non-severe, the amoxicillin would be replaced by cefuroxime. But if the hypersensitivity reaction is severe, we are going to seek the expert advice. So, severe immediate hypersensitivity reaction refers to the anaphylaxis, compromised airway angioedema, and hypotension. And the severe delayed reaction is mostly cutaneous, and these contain the drug rash, eosinophilia, or systemic symptoms are there. Stevenson-Johnson syndrome, toxic epidermal or acute interstitial rash. So these are the delayed hypersensitivity reactions. Now coming towards the moderate severity community acquired pneumonia, we are going to give, if the patient is a candidate of oral therapy, he can tolerate oral therapy, and he can take oral drugs, we are going to administer the oral therapy, and the regimen would be two drug therapy. In two drug therapy, we are going to administer amoxicillin plus doxy or azithro or clarithromycin. But if the patient is allergic to amoxicillin and the patient has non-severe hypersensitivity reaction, amoxicillin would be replaced by cefuroxime. And if the patient has severe hypersensitivity reaction, we are going to administer moxifloxacin in place of amoxicillin, right? But if the patient is a candidate for IV therapy, he is unable to tolerate oral, or he cannot take oral therapy, we are going to shift towards the IV or enteral therapy. So IV benzyl penicillin plus the two drug regimen would be IV benzyl penicillin plus enteral toxiclarithrol and azithromycin. But if the enteral route is not possible, IV azithromycin would be given as a second drug, right? But if again, if the patient is allergic to penicillin, we cannot give benzyl penicillin. So in place of IV benzyl penicillin, if the patient has non-severe hypersensitivity reaction, we are going to give ceftriaxone. But if the patient has in severe hypersensitivity reactions, we cannot, if, penicillin is already contraindicated if the patient has any kind of penicillin allergy. But in case of severe hypersensitivity reactions to penicillins, cephalosporins can also get contraindicated. But if the patient really need beta lactam drug in severe immediate if the patient has severe immediate hypersensitivity reaction to penicillin and the patient has to have the beta lactam, the patient can have ceftriaxone. I'm talking about the moderate severity community acquired pneumonia. But if there is severe delayed reaction, cephalosporin is completely contraindicated and the patient would have moxifloxacin. So in tropical regions, if the patient has moderate severity community-acquired pneumonia, and the patient is in tropical regions, from tropical regions, we are going to manage him. Likewise, the non-tropical side. But if the patient has risk factors for pseudomonal or Acinetobacter, that are the diabetes, increased alcohol intake, chronic kidney disease, or chronic lung disease. He is on immunosuppressive therapy, including steroids. The regimen would be ceftriaxone IV, ceftriaxone IV daily. And if the Acinetobacter baumannii is suspected from the local epidemiology, we are going to add the gentamicin. Now coming towards the high severity pneumonia, community acquired pneumonia, that is very important. If the patient has high severity community acquired pneumonia, and if the patient also have the signs of sepsis or septic shock, we are going to start antibiotic within the first hour of presentation. And we have to take the blood cultures immediately before the antibiotics, two blood cultures before the antibiotic administration. We also have to take sputum samples, but we do not delay antibiotics to collect the sputum samples. So we are going to follow the two drug therapy, that is ceftriaxone, IV ceftriaxone plus IV azithromycin for high severity community acquired pneumonia. But if the patient has severe immediate hypersensitivity to penicillin, we are going to be giving moxifloxacin instead of ceftriaxone. And if the patient has high severity community acquired pneumonia and he is from tropical regions, we are going the high severity community acquired therapy would be meropenem and azithromycin. IV meropenem plus IV azithromycin would be given if the patient has high severity community acquired pneumonia and he is from tropical regions. Now we have the additional therapy to be used in high severity community acquired pneumonia. And if we are suspecting the viral organism that the patient according to the local epidemiology, we are suspecting influenza or SARS-CoV-19, we are going to add the empirical antiviral therapy to the above empirical antibacterial therapy while awaiting for the NAT and PCR results. Then we have corticosteroids. Corticosteroids are not recommended in every case of community acquired pneumonia, high severity community acquired pneumonia. They are recommended when there is a concurrent indication. What can be the indications for steroids that are sepsis or septic shock? The patient has a COPD, the patient already have a COPD and he has got pneumonia and he has got the COPD exacerbation, and the patient has SARS-CoV virus. So we are going to administer the the steroids. And if the patient is critically unwell adults and he do not have any of this concurrent indication, the steroid still have the mortality benefit. So we are going to administer the steroids in the critically unwell patients. And steroids, we have to avoid steroids in cases of influenza A, B, mycobacterium tuberculosis, or fungal pathogens. If they are likely to cause the pneumonia, we are going to avoid these steroids. If the patient is critically unwell and he requires high flow oxygen or mechanical ventilation, we are going to add hydrocortisone within 24 hours of diagnosis. Now we have a treatment for a highly rare organism, but it can cause a very severe pneumonia, as I talked in the first video when I was telling about the pathogens of the pneumonia. So empirical therapy for the suspected Staphylococcus high severity community-acquired pneumonia. It can be caused by MRSA or methicillin-resistant Staphylococcus aureus or methicillin sensitive. Staphylococcus or staphylococcal pneumonia can occur primarily or most of the times it is followed by influenza, following the influenza infection. Or it can be metastatic complication of Staphaureus bacteremia, or if the patient has right-sided endocarditis or he with the history of IV drug abuse, he can metastasize the organism to the lungs and the patient can have staphylococcal pneumonia. The features that suggest the staphylococcus pneumonia are the cavitary pneumonia and cavitary lesions on the chest X-ray, and it is most likely after the influenza infection. The pneumonia is rapidly progressive. So the regimen and the treatment of choice would be vancomycin. The treatment of choice in the case of Staphylococcus aureus pneumonia would be vancomycin. Now we have the empirical therapy for Pseudomonas. In high severity community-acquired pneumonia with known colonization of sputum with Pseudomonas aeruginosa. Example, most of the times it is in the patients of bronchiectasis or the patient has sepsis or septic shock. We are going to suspect Pseudomonas aeruginosa, and the treatment of choice would be cefepime or piperacillin plus tazobactam. This treatment plus azithromycin IV plus if the patient has sepsis or septic shock, we are going to add tobramycin or gentamicin. Let me repeat. Cefepime or piperacillin plus tazobactam in one place, then we are going to add azithromycin IV. And if the patient is in the state of shock or sepsis, we are going to add tobramycin and gentamicin. But if the patient has severe hypersensitivity history or reaction, we are going to replace cefepime with meropenem. So I have tried my best to summarize and to read the guidelines and to put it forward for you. And I have written the antibiotics so that it makes it easier for you to go through the guidelines. You do not have to read all the text that is written there because it is quite difficult and it is quite time consuming. So if you have to see the management of pneumonia, first go through my video and it can give you the overview, what are the antibiotics important. Then you can go through the ETG guidelines or Australian guidelines so that you would know what is important and what's not. So if the patient symptoms get resolved within 3 days, we are going to stop the antibiotic in 3 days in cases of low and moderate severity pneumonia. If the patient is on oral therapy, we are going to stop the therapy and on 3 days if the patient's symptoms get resolved. But if not, we can take the drug therapy to the 5 days course. And if the patient do not get stable on the 5-day course, we are going to step up the therapy. We are going to move towards the second line therapy, or we will assess the patient for any other differential diagnosis. So the symptoms, cough, like a cough, dyspnea, and fever, these get resolved earlier, but the fatigue and the chest infiltrates, they take time to get resolved. So you do not alter the therapy by seeing the chest X-ray because infiltrates get time to resolve. So that's it for the management of the pneumonia. If you like my video, please subscribe the channel and comment below if you have any feedback regarding the video, and if you have any query, please let me know. Thank you.